Hello everyone, welcome to Radiology Case Review Series. In this video, we are going to look at the imaging of a 50-something-old patient who presented to emergency department with altered mental status and unequal pupils. I'm going to start with the CT head images, which is what the patient first underwent. So on the axial CT images, we can see old infarction with encephalomalacia and gliosis. We can ignore that. As I scroll down further, you can see hypodensities involving ventromedial aspect of bilateral thalami, and as I scroll down further, you can also see hypodensity involving the right side of the midbrain. So patient subsequently underwent CT angiogram of the head. On the CTA of the head, we see normal middle cerebral arteries. As I scroll down further, the posterior cerebral arteries looks normal, the top of basilar artery looks normal. Again, on the coronal images, we can see normal basilar artery, normal posterior cerebral arteries. We can also see the superior cerebellar arteries. On the sagittal images, we can see the normal internal cerebral veins, vein of Galen, straight sinus and torcula. Patient subsequently underwent MRI brain examination. On the axial FLAIR images, we can see the old infarct in the frontal region. We can see high signal in the bilateral ventromedial thalami extending into the right side of the midbrain. On the DWI sequences, we can see restricted diffusion involving bilateral thalami extending into the midbrain. Constellation of imaging findings is consistent with artery of Percheron infarction. Patients classically present with triad of altered mental status, vertical gaze paralysis, and memory impairment. Vertical gaze paralysis is due to involvement of oculomotor nerve. In our patient, the neurologist did notice that patient had oculomotor paralysis. Classically, the thalamus and midbrain are supplied by perforating branches arising from the P1 segment. In this article from AJNR, which nicely illustrates the various imaging findings in patients with artery of Percheron infarction, you can see on the illustrative images the thalamus to be supplied by the perforating branches from P1. In artery of Percheron variant, there is a single unpaired trunk which supplies the bilateral paramedian thalami and rostral midbrain. Also, when we see bilateral thalamic lesions, it's important to exclude other etiologies including vascular causes such as top of basilar artery syndrome or occlusion of deep cerebral veins. There are also a number of other etiologies which can cause signal abnormalities in bilateral thalami. I would strongly recommend anybody who is interested to learn more about this topic to refer to this radiographics article. I hope you found this study to be informative. Thanks for your attention.